Good afternoon, sir. Good afternoon, all. Myself, Denisha, and she's Hema. We are here to present a case on adult congenital heart disease. Mrs. Shrikala, 45-year-old female patient whose tailor from Takkalai came to the OPD with the chief complaints of chest pain for the past 15 days. History of preceding illness. The patient was apparently normal 15 days back. Then she developed left-sided chest pain, which was insidious in onset, gradually progressive, pricking in nature, intermittent and non-radiating. The pain aggravated on physical activity and relieves on taking rest. No history of exertional dyspnea, no history of syncope, no history of palpitation, no history of fatigue, no history of orthopnea, no history of PND, platypnea, no history of cyanotic episode. The patient not presented with fever at present, limb swelling, abdominal distension, right hypochondrial pain, hemostasis, cough and reduced urine output. Past history, history of recurrent respiratory tract infection, no history of suggestive rheumatic fever, no history of prolonged fever, no history of previous surgery, no history of diabetes mellitus, hypertension, tuberculosis, asthma and epilepsy. Drug history, the patient takes Ayurvedic medicine for respiratory illness. Personal history, mixed diet, normal sleep pattern, normal bowel and bladder habits, no history of substance abuse. Menstrual history, the patient undertakes menarche, 14 years, regular 3/8 28-day cycle, obstetric history, 2 children, normal vaginal delivery, tubectomy done 18 years back. Family history, no history of heart disease in family members, born out of non-consanguineous marriage. Summary, a 45-year-old Mrs. Shrikala with left-sided chest pain for the past 15 days, which was insidious in onset, gradually progressive, intermittent, pricking in nature, non-radiating, aggravated on physical activity, relieves on taking rest, history of recurrent respiratory tract infection. The probable system involved is cardiovascular system.
One simple question. Tell me the causes of chest pain.
Ischemic heart disease, aneurysm, pericarditis, constitutive pericarditis, aortic aneurysm, dissection of aorta. Dissection of aorta.
Dissection of aorta. That mimics MI. Non-cardiovascular causes.
Pleuritis, pneumothorax, pulmonary embolism, esophagitis, peptic ulcer, cholecystitis, acute pancreatitis.
Good.
What are the pain sensitive structures in the chest? Skin, is the skin pain sensitive? Skin. Anything in the skin can help this obstruction. Is the muscles pain sensitive? Yes. Is the bone pain sensitive? Yes. Is the joint pain sensitive? Yes. You are thinking about the aortic dissection and all this. You think about the common things first. What do you think is the pain due to in this patient?
Due to ischemic heart.
Ischemic heart disease.
No, ischemia. Due to it is not specific pains.
So what are the different manifestations of coronary artery disease? Ischemic heart disease. No, manifestations. One is one is stable angina, 2 unstable angina, 3 acute myocardial infarction, 4 congestive cardiac failure, 5 arrhythmia, 6 sudden cardiac death. These are the various manifestations. Out of this, if it is ischemic heart disease, what is this? It is not angina. You now you are taking it is not ischemic. Then what is the pain? Now this patient came to you with chest pain. She wanted diagnosis from the history. What are the probabilities? You think it is due to cardiovascular system? No. Why you decided that this is due to cardiovascular system? What are the points? Is there any point to say that this pain is cardiac in origin?
Pain is in the left side, it is localized.
So you are mentioning that ischemic or cardiac pain is left side. Is it? No? Cardiac ischemic pain is left side. It is a retrocessional absent. Still it could be cardiovascular system. Okay, what points are there in this patient? What is by your own? What is meant by recurrent respiratory tract
Tonsillitis, more than 5 episodes of tonsillitis in 1 year, more than 3 episodes of otitis media in 6 months, and more than 4 episodes of
What is the reference? Just an interesting definition. It may be true. Recurrent respiratory tract infection may be due to some congenital heart disease. That is the only thing in this patient. And recurrent respiratory tract infection is respiratory tract infection recurring hospital admission of more than 3 times in a year requiring parenteral antibiotics. That is recurrent respiratory tract infection. More than 3 times requiring parenteral antibiotics.
In which disease? Which mental heart disease? The history of recurrent respiratory tract infection. Name you.
Why? In these conditions there is increased respiratory. Very good. So you can classify the congenital heart disease into congenital heart disease with increased pulmonary blood flow, congenital heart disease with normal or reduced pulmonary blood flow. In congenital heart disease with increased pulmonary blood flow, you can get recurrent respiratory tract. As you mentioned, ASD, VSD, PVD.
after getting consent.
ഒരു 45-year-old young lady with chest pain, breathlessness ഒക്കെ വന്നാൽ നമ്മൾ ആദ്യം ആലോചിക്കുന്നത് we will think of respiratory tract infections അല്ലേ? Cardiovascular അല്ല, respiratory ആണ് സാധാരണ. With no previous history of heart disease, with normal 2 deliveries, normal deliveries. And if there was any congenital heart disease, this would have been diagnosed during delivery, during pregnancy. No, 2 normal deliveries, uneventful deliveries. 45-year-old young lady with no previous history, coming with chest pain and breathlessness. I first think of respiratory tract infection. And all the respiratory, how will you differentiate respiratory asthma from cardiac asthma? Cardiac dyspnea, respiratory dyspnea, for your information, orthopnea can occur in both. END agree. There are many causes, many things in which differentiate. Respiratory, there will be childhood history, there will be atopy, there will be family history, early morning age, whatever history of cardiac disease, history of END will be there. And on examination, what is the most important difference? Bilateral, wrong eye will be in respiratory, bilateral basal crepitation in cardiac. And treatment probably respiratory response to bronchodilators, whereas cardiac response to diuretics.
After getting consent and giving adequate privacy, patient was examined. Patient was conscious, comfortable, oriented, moderately built and nourished, no pallor, egress, cyanosis, clubbing, generalized lymph node enlargement and edema. No musculoskeletal abnormalities and dysmorphic features like simian crease, clinodactyly, flattened nasal bridge and sandal gap. Vitals. Pulse is 60 beats per minute, regular, normal volume and character, vessel wall normal, no radiofemoral delay, no radio-radial delay, and all peripheral pulse felt equally. Blood pressure 110 bar 70 millimeters of mercury in left arm supine position, 130 bar 80 millimeters mercury in right leg supine position, 130 bar 80 millimeters mercury in left leg supine position. Respiratory rate 21 cycles per minute, regular thoraco-abdominal, JVP not raised, and patient was afibrilate.
What prompted you to take blood pressure in 3 minutes? Routine ആയിട്ട് നോക്കൂ. Right leg, left leg. എന്താ coagulation? I came to you with complaints of chest pain. What prompted you to examine the right and left lower limb blood pressure? Deferred.
Right arm here.
Say.
On inspection, chest wall bilaterally symmetrical in shape, no chest wall deformity, no precordial bulge, trachea appears normal, apical impulse not visible, no visible pulsations and dilated veins. On palpation, trachea central and apical impulse felt in the left tooth intercostal space at mid-clavicular line. Normal in character, no left parasternal heave, no palpable thrills. On auscultation, in mitral area, S1, S2 heard, no murmur. Tricuspid area, S1, S2 heard, grade 2 mid-diastolic murmur heard. And on pulmonary area, S1, S2 heard, S2 wide and fixed split, grade 2 ejection systolic murmur heard. Aortic area, S1, S2 heard and no murmur. Other system examination, respiratory system, normal vesicular breath sounds heard, no added sounds. In GI examination, no organomegaly, no normal bubble sounds heard. Nervous system examination, no focal neurological deficit. Summary, a 45-year-old female patient with left-sided chest pain not amounting to angina with history of recurrent respiratory tract infection. On examination revealed wide and fixed split of S2 and grade 2 ejection systolic murmur in pulmonary area is probably a case of acyanotic congenital heart disease, atrial septal defect with left to right shunt with no evidence of any complications like pulmonary hypertension, cardiac failure and infective endocarditis.
This I should say it is an accidental finding. ASD. Chest pain act on the no other conditions. It is an accidental finding. Many a time ASD may be detected like this. It can remain asymptomatic for quite a long time. And it is detected by accidentally finding a murmur. ഇപ്പോഴും അവിടെയാണ് സംഭവിച്ചത്. What are the points to say it is ASD? After examining, why you said it is ASD?
Sir, wide and fixed split of S2, sir.
Is ASD is common in which male or female? What is the ratio? It is 2:1. Correct. Yes. It is more common in female. Then, what are the points in favor? From history of recurrent respiratory tract. That is the hallmark of acute septal defect. It is wide and fixed, second heart sound. Why it is that like that? Wide fixed.
During inspection, there is an increase in venous pressure, so that there is a split in
What do you mean by fixed?
So split is fixed because there is constant end diastolic volume overload in right ventricle. Fixed, there is no respiratory variations. So it is due to constant end diastolic volume overload of right ventricle. So no more blood can enter the right ventricle.
What murmur does VSD produce?
Pansystolic murmur in moderate size PSD. If it is small or large, then it is ejection systolic murmur.
What murmur does ASD produce?
ASD, there is no shunt murmur. Flow murmurs like
in pulmonary area and end diastolic murmur in tricuspid area.
Why ejection systolic murmur in pulmonary area?
Due to delay in V2 and early
Why murmur?
increased blood flow to the body.
What are types of ASD?
Ostium primum ASD, ostium secundum ASD, sinus venous ASD, coronary sinus ASD.
Which one is common?
Ostium secundum.
Which congenital anomaly can be associated with the voice?
It's a Hall-Torrens syndrome. Hall-Torrens.
Which valvular lesion is associated with the ostium secundum?
Describe the development of the atrial septum. If you get an ASD, they will ask you the development of atrial
The patient is treatment for the
premature atrial singular. അതിന് ആദ്യം എവിടെ നിന്ന് ഓസ്റ്റിയം പ്രൈമം എവിടെ നിന്ന്? There are three. One is ostium primum, ostium secundum, three is AV or endocardial. ആദ്യം ostium primum will come from above. No. പിന്നെ why there should be a communication in the detail? You should rate the development of atrial septum. They will ask. What are the different types you mentioned? Common is ostium secundum. How will you differentiate? Is there any way? Easy. ECG. No.
There is right axis deviations and incomplete right bundle transplant. And in ostium primum, there is left axis deviation with ectopic right bundle transplant.
Sinus stenosis.
Sinus venosus, there is inverted P in A2 and without junctional venosus.
Prolonged ER. Very good. What is the complication?
Partial anomalous pulmonary extent.
Complications. ED elevation.
Pulmonary stenosis, atrial fibrillation, Eisenmenger syndrome. Right ventricular hypertrophy.
What is this Eisenmenger syndrome? What happens is in Eisenmenger syndrome, which one develop first? ASD, VSD, PDA. PDA is the first to develop, second occur. PDA develop first. How will you know that there is Eisenmenger syndrome in a PDA? What happens in the second? There will be differential coupling in PDA. Reverse bridge. Second is VSD. It is in the third decade. What happens to the second sound? Good, single S. And later, last is ASD. It occurs in the fourth decade. What are things occurs in when Eisenmenger develop in ASD? ഇതൊക്കെ ആർക്ക് എക്സമെങ്കിൽ വന്നാലും വരും. ASDK, BSDK, BDK. Everybody. What happens in ASDK? What is paradoxical embolism? I will give a clue. If the ASD develops isometric syndrome, two sounds will appear, two sounds will decrease, and two findings will occur. Murmurs, new murmurs will appear. Two sounds will appear. There will be a pulmonary ejection kit and RVS. S1. The two murmurs usually there will be reduced, and two murmurs will appear. ഏതൊക്കെ murmurs will appear? ER murmur and ER.
What is grand sleep murmur?
Any differential diagnosis for this? No. Clinically, any differential diagnosis? For white fixed spleen. X. Then എന്തുകൊണ്ടെന്ന് അറിയാമോ? Partial anomalous venous condition. Even VSD is a differential diagnosis. Truncus ventricular, truncus. These are the differential diagnoses. How will you investigate this? This is access business. എന്താണ് ഈ ആക്സസ്? It's access. Easy. എന്താണ് ആക്സസ്? It's a combined electrical activity. That's all. ഓരോ ചേമ്പർ എൻലാർജ്മെന്റ് വരുമ്പോഴോ ഏതെങ്കിലും MI വരുമ്പോഴോ ഇതിന് വ്യത്യാസമില്ല. Okay, so we will give distinction mark if you answer this. We give a differential diagnosis for this X-ray. ASD X-ray, give a differential, immediate differential diagnosis. X-ray. Anybody? We know for sarcoidosis.
Echo-wise, when you will say small VC, when you will taste age. No. When you call small, when you call medium, when you say large age. No, based on the echo, the defect, based on the defect size. Up to 3 or less than 3, small. More than that, up to 3 to 6, it is medium. More than 6, large age.
medical management. ചുമ്മാ നടന്ന ഒരു പേഷ്യനെ പിടിച്ച് ഓപ്പറേഷൻ.
Which part they close the immune sheath? What's that sheath?
When will you do this? Close.
Pulmonary shunt is more than pulmonary shunt is 1.5 to 1.5 is to 1.
So when the ratio of pulmonary flow is to systemic flow is more than 1.5 is to 1, surgery is needed.
When will you not do surgery?
Medicine and medicine.
Why? അതുകൊണ്ട്
It will cause post-operative complications. Cardiac
Postoperative complications is there for any surgery. Tell some associations of ASD. Inside ASD can be associated with mitral regurgitation, ostium.
It is associated with MS,
No, what is Luton-Backer syndrome?
acquired MS and congenital ASD.
Very good. ഇങ്ങനെ തന്നെ പറയണം. Acquired mitral stenosis and congenital aortic acute septal. Then any other? What is Edwards syndrome? Good. Absent radius. Down syndrome. Down syndrome and no association. Short arm. ASD with absent radius. Good.